Good morning. Thank you. Love the chatter this morning, a lot of energy in this room. Thanks for being here. My name is Holly Brenner. I'm the Vice President of Strategic Development and Marketing for the system. I appreciate that you made time to attend our No and Go Friday showcase this morning. I think it's going to be a great one. We'll get started with a reflection this morning, and this one is called You Are an Inspiration. Your presence is a gift to the world. You're unique and one of a kind. Your life can be what you want it to be. Take it one day at a time. Count your blessings, not your troubles, and you'll make it through what comes along. Within you are so many answers. Understand, have courage, and be strong. Don't put limits on yourself. Your dreams are waiting to be realized. Don't leave your important decisions to chance. Reach for your peak, your goal, and your prize. Nothing wastes more energy than worrying. The longer a problem is carried, the heavier it gets. Don't take things too seriously. Live a life of serenity, not a life of regrets. Remember that a little love goes a long way. Remember, too, that a lot goes forever. Remember that friendship is a wise investment. Life's treasures are people, together. Have health and hope and happiness. Take the time to wish on a star. And don't ever forget, for even a day, just how very special you are. So we have a couple of housekeeping things before we get started with the program. We have Shelley with us and our associates in Waupun, and Danelle is over in Ripon with our associates there. We have the yellow comment cards that you know we really appreciate the comments and the feedback that you provide. We work very hard to incorporate any changes and suggestions that you have. I think today's topic was actually one of those as well, so thank you for that. We're changing things up today, getting pretty radical on you. You don't see the blue slips today, we have green slips for you. Apparently we needed a reprint. But this, if you want to be entered to win the door prize today, please fill that out. If you're interested in receiving credit for being here this morning, please include your associate ID number on the back. And finally, for next month, we have a very exciting program and a great prize, it looks like. Friday, October 11th is our Friday No and Go Showcase for October, and this will feature some of our providers over at the Agnesian Cancer Center, so that'll be a great program as well. So just as a reminder, our No and Go Fridays are really designed to help educate us as associates on the important health information and topics, and also to introduce us to the professionals within our system who provide those services. So in the event that you or someone that you care about is in need of one of our services, you'll be really well informed. So join me today to welcome Dr. Ben Smith. He's a board-certified interventional radiologist with Radiology Associates of the Fox Valley. And so today we're going to learn a little bit more about the role interventional radiology plays in patient care. So, Dr. Smith.
All right, awesome turnout. Thanks for coming out this morning. Title of my talk is Interventional Radiology, some pretty neat stuff because I think what I do is really cool. And we're going to share a little bit about what we do up in the cath lab and what our capabilities are today. As a brief overview, I'm going to just talk a little bit about what it takes to make somebody like me. I'm going to talk a little bit about the history of interventional radiology and some of the developments, technological advancements that have been brought about because of interventional radiologists. I'll talk a little bit about the toys I get to play with upstairs, and then of course we're going to talk about some of the procedures that we do currently here at St. Agnes. First of all, what does it take to make somebody like me? Well, first of all, you got to get your bachelor's degree, and depending on how hard you party, typically it's 4 to 5 years. And you have to go to medical school. So I went to medical school at the University of Iowa. That was 4 years of fun. You have to do an internship, which is just sort of a 1-year super slave ordeal. Then you do your 4 years of residency, and for interventional radiology, currently it's a diagnostic radiology residency. So you learn how to interpret images and how to acquire images properly. It's sort of the gist of it. But you also you get exposed to interventional radiology during those 4 years. So you do rotations every year on the IR service. And then last, you do your fellowship training. Your fellowship training is sort of your subspecialty training, where you do nothing but interventional radiology. And I did medical school at the University of Iowa. My internship actually in La Crosse, Wisconsin, and that's why I wanted to come back to Wisconsin, because I just love the people here. And the residency and fellowship, I was at Duke, which is in North Carolina. So 14 years of training after high school. It was a lot of fun. These are the interventional radiologists in my group, and they're 9 of us total. We have 2 neurointerventionalists, which would be Dr. DiCasso and Dr. Peebles, and they coil aneurysms and do stroke work and such at some of our other hospitals. And then several other fellows. The guys that are here most commonly are myself, Dr. Hartman, Dr. Garofalo, Dr. Asbury. So they got quite a cast of characters here, and everybody's a little bit different, as my cheering section over here will attest to. Everybody has a little different taste in how they do things. Interventional radiology is an incredibly innovative specialty. Basically, it's imagination applied to technology, and it's unbelievable some of the things that have been developed over the years to basically solve problems that didn't have really, for patients that didn't have better options. And the other interesting thing is the procedures we do, they span the entire spectrum of human pathology. I mean, I interface with nephrologists, vascular surgeons, neurologists, you name it. I have sort of procedures or treatments that I can offer pretty much across any specialty. So I think that's one of the reasons why interventional radiologists sort of toil in obscurity, is that we offer a few solutions for a wide variety of problems. And of course, as a result, we don't have like a single identity. I'm not just a vascular guy. I'm a urology guy, a nephrology guy, all these things. Very briefly, IR history. Interventional radiology has actually been around a long time. There have been a lot of developments over the years for interventional radiology. And the landmark development, the two big things were, number one, Seldinger access, which is basically the way we get into whatever we're getting into, be it a kidney, a blood vessel, whatnot. There's a guy named Sven Seldinger who was a Swedish radiologist, and I think in '54 is when he developed his technique, which is basically you puncture an artery with a needle. Of course, the needle's hollow, so you just slide a wire through the needle. The wire acts like a rail, and then you can move catheters and balloons and everything over that wire. Okay, and that sort of revolutionized or changed our ability to actually get things done. But the real big thing was in 1964. It was Charles Dotter out at Oregon Health Sciences University. He's an interventional radiologist, and he's the guy who actually proposed the idea of angioplasty, which means to stretch a blood vessel open. And Dotter did that, ironically, on a vascular surgeon in, I think, '65, whose leg was going rotten because it didn't have any blood flow to the foot. And he did the angiogram, and he stretched the blood vessel open, although interestingly, he didn't actually use a balloon, which is what we use today to stretch vessels. What he did was he had these tapered sticks, more or less, and he sequentially used bigger and bigger sticks to stretch open this artery from the inside. And it healed the surgeon's foot, and it was nothing short of a miracle. I mean, it was a revolutionized medicine. Interventional radiologists invented stents. Julio Palmas invented the balloon expandable stent. They developed embolization procedures, which means plugging up of arteries from the inside to treat things like life-threatening bleeding. Clot busting techniques that we use, for example, in stroke patients. Those were invented by radiologists. Tumor ablation, where we place a needle or a special type of applicator inside a tumor and basically cook the thing or burn it or freeze it. Laser ablation, and actually, interestingly, a lot of cardiac procedures originated from interventional radiologists. There's one of Dotter's partners was a guy named Melvin Judkins, and he developed a lot of the heart catheters that are commonly used today. So what are some of the tools we get to use? Well, I get to play with all kinds of just totally awesome toys. I love the stuff that I get to play with. It's really neat stuff. And so I'm just going to basically show you some pictures, and I have lots of them here that we'll start passing around here in a minute to get your hands on some of the things that we do and get you an idea of the sort of the scale at which we work. We don't talk about incisions in terms of centimeters. We talk about them in millimeters. I mean, the biggest incision I typically make is 4 or 5 millimeters. All right, it's very, very small, and that's usually more than enough room to accommodate the things that I need. So we'll talk about the Angio Suite, which is where we work, the catheters, the wires, balloons, and various other items that we use to accomplish our job. This isn't actually the suite here at St. Agnes. I have to just say on the side that the Angio Suites here at St. Agnes are wonderful. They're beautiful, they're spacious, they're well equipped, and they're just a pleasure to work in. And I'll put those up against, the place I train, our suites are better than where I trained. This is the C-arm, or the X-ray machine. Most of the stuff that I do, I use X-rays as my guide. Okay, as a radiologist, everything I do, I have to see. I'm lost without my eyes. So if I use ultrasound, CT, X-ray, that's what I'm using to guide the procedure. So everything's sort of predicated on the ability to see what we're doing, and that's what makes these procedures so safe and gives us an incredible level of precision in what we do. So you can see that we have the C-arm, which is the X-ray tube, and this thing can rotate around so that I can look at the patient from the side, from the front. That's important because everything I do is a 2D or 3D object, that's reproduced in 2 dimensions. So you have to look at it from several different projections to know exactly where something is located in the body. We have monitors here. This is where I take pictures and watch in real time what I'm doing. This screen over here, usually I'll save pictures as a reference to know where I need to go. And then, of course, you have all your toys in the back here. This is a Pyxis system, crash cart and such. The table actually has a lot of controls. All the controls with the table. I can move the table around, rotate the beam, collimate the images, manipulate everything. One of the most basic tools that we use are called catheters. All right, and this isn't like the catheter that goes in somebody's bladder. These are much, much smaller, and they have special shapes that allow me to perform special functions. Probably the thing that we most commonly use is I just use a little hockey stick type catheter. If you think about this, I mean, I'm using these catheters to get places. So this type of catheter here, if you think about how if you spin it on its axis, this little hockey stick here, it's going to point that direction or that direction, and I can use that to get into various different blood vessels. So that's just one example. Sometimes you have to use catheters that face backwards like this one to get into other vessels, and it just sort of depends on which blood vessel you know you want to get into. That helps you pick your catheter. And not uncommonly, the one you think is going to work doesn't work, and you might have to use a couple, 3 catheters. And we have some examples of catheters up here that we can start to pass around. Wires, it sounds sort of, I don't know, kind of boorish, but we use wires actually through the catheter. The wires are very small, they go through the catheter, and they're kind of a rail, all right? That's what we work over. So what we try to do is use the catheter and the wire to get to where we want to go, and then we leave that wire in place to work over, all right? That's our working rail. It's like laying down railroad tracks. Train rides the railroad track out to where the work needs to be done, and it takes care of business. And those wires can range anywhere from the standard size wires, 35 1/1000ths of an inch, all right, down to 10 1/1000ths of an inch or 1/100th of an inch. So they can be extremely small and delicate wires, depending on the job, where we need to go. We use balloons to perform angioplasty this day and age. So balloons, there's nothing fancy about it. It's just a device that we fill up with fluid. It stretches, you can see here, there's a blockage in the vein. Use the balloon, you can see how tight this blockage is, that the balloon doesn't want to fully expand, but if you increase the pressure enough, it'll expand all the way, opens the vein up, takes the pressure off above where the blockage is. And then last, actually not last, but they're also stents. And stents are just like I don't know if you've seen those Chinese finger cuffs. A stent's a lot like those. It's sort of a wire mesh device, and what it does is it wants to expand and hold things open. So a lot of times we use stents for blockages that are resistant to the angioplasty alone. We always try to just be minimum, stretch it open. If it doesn't get better, then you got to call in the big guns, and that's what stents are for. They're to hold things open. Interestingly, here's a little bit of trivia. A lot of these stents are made of a substance called nitinol, and nitinol is nickel titanium alloy, if I recall correctly. This alloy has something called thermal memory. So when it's cold, it wants to be constricted down to the size where it can fit through a catheter. But when it warms up, it wants to expand. It makes it expand. So depending on the temperature of the metal, dictates the shape of the device. And that was a big advancement in stent technology because it allowed us to get the stents down to such a small size that they can fit through our little catheters and over our small wires. Embolics is just a fancy word for a plug. All right, this is what we use to plug up blood vessels. And it may seem a little counterintuitive, why would you want to plug up blood vessels, but there are 2 really common reasons why we do that. One is if you have a patient that's bleeding to death and you want to plug up the artery. Sometimes these arteries are so small, it's just very hard for a surgeon to find them, but they can be life-threatening. An example of that would be there's a patient just recently that had a GI bleed, and that the bleeding vessel, I'm sure, was less than 1 millimeter, and that patient was hypotensive with a pressure of like 60 or so for a while, just because of a 1 millimeter bleeding blood vessel. It can be very hard for my surgical colleagues to locate or find where that bleeding vessel is, but when I inject X-ray dye in the artery, the contrast or the dye just pours right out of the bleeding vessel. So it makes it easy to find the blood vessel and then plug it up. A lot of times for larger blood vessels, we use these little coils here, all right? And you can see the little fibers on these metal coils. We use these because the coil, when it's straight like this, it'll fit through the catheter. Then when it comes out the end of the catheter, it'll make shapes like a coil like this or a tornado or a diamond, and it just mechanically plugs up the blood vessel, and those fibers form clot, okay? And that's what plugs up the blood vessel. The other example of when we need to plug up arteries would be for tumors. You know, tumors, like anything else, they need nutrients, nutrition, oxygen, and such to grow. What we can do is plug up the arteries that supply the tumors, choke off the nutrition, and the tumor will shrink or die. And a lot of times we'll inject these microscopic particles. These are electron micrographs of the tiny particles that we inject through the catheter. The blood flow pushes those particles out to the tiny blood vessels that feed the tumor, plugs those up, no more blood flow to the tumor, tumor dies. And there are a couple of contraptions we use. We use filters a lot. You may or may not know somebody that has something called an IVC filter. This is an X-ray picture of an IVC filter, and this is actually a retrieval procedure. These filters are, they're all approved to stay in permanently, but commonly we take them out. They put a little hook on them, and when it's time to take them out, there's a little lasso, and I've included one of those in our sampling here. You snare the hook, you pull the thing out. I just love doing this procedure. It's so much fun. And then we have other types of filters that, for example, if you don't want gunk to go down the stream to down the blood vessel to distal vessels, such as in the brain, when you're stenting a carotid, you really don't want the gunk to go down to the arteries in the brain because, well, that's what a stroke is. So we have filters to catch all that gunk and pull it out to make carotid stenting, for example, a safer procedure. Okay, now we get on to the good stuff. This is just a kind of a sampling of the types of procedures that I deal with. Deal a lot commonly with blocked arteries and veins, bleeding situations. I treat aneurysms. We treat tumors. We have a couple of procedures that relate to women's health. Clot busting procedures. Drain a lot of abscesses or other infected fluid collections. We manage stroke. We can treat fractures like vertebral compression fractures with vertebroplasty. And then we do a lot of our main businesses, things such as biopsies like lung biopsies, liver biopsies. Do a lot of vascular access. So if there's a patient in the house that nobody can get a PICC line in, they call me and I put the PICC line in the patient. Patient needs a dialysis catheter, I put the dialysis catheter in the patient. And then also patients on dialysis. Dialysis is a very healthcare resource intense condition, and I see these people quite frequently to keep their access, be it a catheter or their fistula, keep it open and flowing properly. Because these veins and these catheters, the body doesn't like those and it tries to shut them down. So we're always fighting to keep those open. So we'll show you a few examples of cases where we have patients with blocked blood vessels. This first case is a patient that basically had an ulcer on their foot, and a lot of times, an ulcer that wouldn't heal, I should qualify that. And a lot of times if an ulcer is on a foot and it doesn't heal, well, the problem is there's something wrong with the blood flow. Either you're not getting enough blood flow and nutrients and nutrition for the body to heal that ulcer, or you've got a problem with the veins where the blood gets in there and it just can't get out, and so it just sort of stacks up and you're not getting fresh stuff in, okay? Well, in this case, it's a patient with a blocked artery. So this is what's called an angiogram, and you can see we inject the X-ray dye here, all right? And you can see how, the nice thing about these is when I do this is you get an idea not only of if the blood vessel will open or not, but what's the blood flow in the blood vessel look like? Is it slow? Is it fast? What's the problem here? So we'll show the angiogram here. And this part of the vessel, this looks pretty good. I mean, there's a little bit of narrowing down here, but no big deal. So we get to the next part of the leg, and this is down by the patient's knee. And whoopsie, that part is blocked up. All right, so there's the problem. That's why the patient isn't healing. Now, the body's a pretty amazing thing, and it likes to bypass blockages. So that's what this patient has done, is they've tried to bypass it. You can see all these other blood vessels here. They're bypassing the blockage, and we're still getting blood flow downstream. It's just not enough to make the patient better. So we need to open this little segment back up, okay? And this is just to show, this is our baseline. I always get a baseline downstream to make sure that if I have a problem down the line, we can identify what that is and fix it. So we basically use the wire in the catheter. You weasel that thing across the blockage, all right? You keep the wire in place, and then we stretch things open and put a stent in. And this is what it looks like after we put a stent in, wide open. Blockage gone. All those little bypass channels, those are gone now because they don't need to work. They don't need to do their job anymore. It's all downstream. So that's a pretty typical leg case, for example. Here's another patient with a complete blockage of a vein in their chest. All right, this is a patient on dialysis. They always get these blockages in their veins, invariably. This is inevitable. And what happens here is if you get blockage right here, all the blood in your arm, it just can't get to your heart. Well, when blood can't it gets static or stagnant and doesn't flow, that's when you get swelling in your arms or legs or whatever. So patients with heart failure, for example, the blood doesn't flow well enough, so they get swelling in their legs. Well, no different here. Patient gets really bad swelling in their arms, it's very uncomfortable. Sometimes their skin even starts to break down. So what I do is snake our wire across the blockage, okay? And this is a balloon. You can see where the blockage is right there to stretch it open. And here again, here are more of those bypass channels, trying to get by it, not working very well. Here's our picture. All the bypass channels are gone, wide open. Beautiful result, swelling goes away. Takes, depending on how difficult it is to cross this, it takes 10, 15 minutes to do this.
Dr. Smith, why does that happen, you say, typically in dialysis patients?
In dialysis patients, in order to filter the blood, you need an adequate blood flow. And so you have to get a high flow source, but which would normally be from an artery. All right? But the problem is you can't puncture an artery all the time. There's a big difference between an artery and a vein. An artery is like a fire hose, and a vein is like a garden hose. Garden hose, no big deal. You can pinch that off, you can deal with it. Fire hose, much bigger deal. So you can't puncture arteries regularly. Plus, arteries are deep and they're hard to feel. So what the surgeons commonly do, like in this patient, for example, is they'll take a piece of vein in the arm somewhere and they'll tie it right into the artery. Veins are very superficial, so you can see where they are, you can feel them. So now all you got really fast blood flow, but it's going into a vein, which is not a big deal. And they puncture the veins. So now you have all this blood flow going through something that's not used to a lot of blood flow. All right? The veins don't like that, so they try to stop it in their own way. So they'll form scars and blockages. Here's a patient who's having leg pain in their left leg with walking. Okay? Sometimes the blockage is not to the point where they can't heal ulcers, but it's severe enough that you get cramps. You don't get enough nutrition when the leg is stressed. And it's just like heart pain, when you got blockage in a coronary artery, well, it's the same thing in a leg. You get a blockage, there's not enough flow when you really, really need it, so you get leg pain when you exercise. And this is a beautiful, this is an MRA, and this is just a 3D rendering of the blood vessels. And we can see here, this is the aorta, renal arteries, and there's a little tiny blockage in the iliac artery in the pelvis. And the gold standard for treating these actually is with a stenting procedure, because that's a big surgery otherwise. So the beauty of doing this, and these are pictures that we get at Agnesian. These are the kind of pictures that we get. The beauty of knowing this is now I know exactly what I need to do, and I can make this, what would normally be, if I didn't have this picture, it would be a 30 minute to 60 minute procedure. Now I can do this in 10, 15 minutes. So here's the angiogram, basically just showing the blockage right there, very tight blockage. You can see why this patient's having a lot of pain. And this is what it looks like after we stent it open, wide open. Very straightforward, very simple. And the size of the incision is, again, maybe 3 millimeters in the groin. We see the patient in the clinic a couple weeks later. You can't even find where you punctured. Bleeding is something that we deal with. Commonly, one of the more common kinds of bleeding that we see are patients with GI bleeding. GI bleeding can be life-threatening. And this is an example of a patient who had a life-threatening bleed. In fact, their bleeding was so severe that the endoscopist, normally in the stomach or upper belly, it's better and safer to use the endoscope, or one of our GI doctors goes down with a scope and they try to clip off the bleeding blood vessel because they can see it and they can clip it. Here they left in a whole bunch of clips and they just could not get this thing to stop. So they called us to take the picture, and it's going to be kind of hard to see this, all right, because the lights are up. But there's this vessel here, this is the left gastric artery, and if you watch it over here, if you look, you can see the contrast starting to pour out right here. All right, so that's just blood. All right, the patient's pouring out blood right here. All right, that's the spleen if you're wondering. All right, so now I got to get into this blood vessel because I just want to plug up this one little tiny blood vessel. Leave the rest, the rest of the body needs its blood flow. So we'll take some pictures here. It turns out that this is the little 1 millimeter vessel right here that goes out to where the bleeding is. All right, so sometimes it takes a while to figure out where the actual bleeding is. So now, through this catheter here is about 1 2/3 millimeters in diameter. Now I've got a catheter here. This is a 1 millimeter diameter catheter that I fit through this guy. That gets me clear out to this little 1 millimeter blood vessel. And here's the vessel that I'm going to get into right here. And you can see here's the bleeding right here in this little guy. All right. There's some of the blood right there, right there. So what do? We put those little metal coils that I showed a picture of earlier because those can fit through this catheter. So here's our little plug of coils in that last little blood vessel. No more blood flow, no more bleeding. Patient stabilizes just like that. It's awesome when you do this. All right, and all they have is a little tiny 3 millimeter incision in their groin. Okay. Here's another example. This is a patient that sometimes patients get these Lovenox shots, and they kind of get locally the Lovenox is to thin their blood. And unfortunately, sometimes what does is those injections, they actually go, they're supposed to be just into the fat on the belly, but some patients are really thin, or they don't do it properly, and it gets into the muscle wall, or where your six-pack is. And they can start to bleed right there. And sometimes they bleed, it just gets out of control. And it can be life-threatening. And here's an example of a patient with one of those bleeds. If you look here, this is a CAT scan. This is like a slice right through the middle of the patient here, looking from their feet towards their head. And you can see this big mess. This is the X-ray dye that's actively bleeding out into that six-pack muscle. All right, this part here is just blood that's layering. And they've got a great big black and blue spot, lots of pain, and their blood pressure is dropping because it's hydraulic fluid. If you start leaking hydraulic fluid, if you don't replace it or stop the leaking, you can't keep the pressure up. So I have just a static image, and in this particular case, you just see all these little micro tears in the muscles that are bleeding. What we did was we punctured actually the other groin. I slipped the catheter over the top, down, and then back up. So my catheter tip is actually right here. All right. This is what's called the inferior epigastric artery. But the problem is I can't really puncture it from here because this artery, you can see how close it is to where I would normally puncture. It's very difficult to get into. So you got to take this really circuitous route to get there. And what would you do? We just, again, more of those metal coils to plug up the artery. No more bleeding downstream, patient stabilizes, okay? Treat a lot of aneurysms, all right? Aneurysms are another thing that I really enjoy managing. This is a really neat case. This is a gal that was 85, and this particular case actually did well at Duke, and this patient wrenched her back body surfing. So she came in complaining of some back pain. She was body surfing, 85-year-old, she was awesome. Wrenched her back body surfing. We did a CAT scan, and just lo and behold, what's this? Well, this is an aneurysm, and this is sort of the classic type of aneurysm people think of, a bulge in the artery. And an aneurysm, interestingly, the way to think of an aneurysm is sort of like a garden hose that has a nick in it. There's like an inner bladder or lining on a garden hose. When you get a nick in that garden hose, that inner bladder kind of pooches out. You've probably all seen that. And that little part there, it looks very weak. Well, it's because that wall is thin and weak, and that's why aneurysms rupture, because their wall is thin and weak. So you have to stop the blood flow in those aneurysms, take the pressure off them so they can't rupture and bleed, all right? So this is a picture of the angiogram. We've got our catheter in place. Here's the aneurysm. Here's the blood flow going in, and there's going to be a vessel. You don't see it very well, but there's a vessel coming out here. And again, we just put in a couple coil packs, no more blood flow in the aneurysm. Patient did fine. The aneurysm clotted off, and they start to shrink once they do that, and she's no longer at risk. This is something that we do not uncommonly here at St. Agnes. This is an aortic aneurysm. This aneurysm is a little bit different, okay? It's not the classic sort of pooch out the side. These aneurysms typically are what we call fusiform, which is they're tube-like. The whole wall of the blood vessel is weakened, so the whole wall pooches out, not just one spot on the wall of the artery, okay? So the patient is prone to rupturing this anywhere along here, and certainly when it reaches a size of 4.5 to 5 centimeters, you've got to fix these, otherwise the patient's at a high risk to rupture this aneurysm, okay? So you can see here, this is what the normal aorta should look like. This is normal caliber, but here it pooches out, and that's just too big. So this is an aneurysm here that I did here, I think back a few months ago. So what do we do? Well, you can kind of see the device. What we do is we actually reline the inside of the aneurysm. There's actually a prop here that shows what it looks like. It's a special stent that has a piece of fabric sewn onto it. And what we do is instead of, the way they used to fix the aneurysm, they clamp the aneurysm and sew a new tube into the aneurysm all the way down to the legs. All right, that excludes the blood flow from the aneurysm itself, takes the pressure off the wall, no more risk of rupture. Well, a quicker or a safer way to do it is actually just to reline the inside of the aneurysm and redirect the flow through the tube from the inside. And that's what this procedure is. We just reline it from the inside. So we have our stent graft, which is the name of the device that actually relines the inside. You can see it here, and we're trying to position it. We don't want to cover up the arteries to the kidneys because we don't want to choke the blood flow off to those. So we take our pictures to try to figure out where to put that. Now we got it in the right spot here. This is the tip of the graft. These are renal arteries here, so I can just let it go and it's going to deploy right there. There's a big magnification image. This is a beautiful deployment. We preserve this smaller renal artery, and the blood flow now is going down the tube instead of the aneurysm. And you can see here, interestingly, the other thing about these procedures that's a little challenging is we actually put the device together inside the patient. And each patient is different, so we actually have to custom, we always do CAT scan beforehand. We take very precise measurements to custom order the device for each patient. Every patient's different. So you have to get the right size device for each patient. So we order in the device, do the procedure, and then I put it together actually on the inside of the patient and reline the aneurysm and the arteries that go to the legs here. So this is what it looks like when we're done. Remember that pooching before? No more pooching. All the blood flow is going down the new tube. The pressure is off the wall of the aneurysm. Aneurysm shrinks, patient safe.
So you wouldn't have just the one iliac as
Well,
well?
this procedure actually requires both iliacs, okay? This one, because the devices are so large, you have to have incisions in the groins. So the incisions are about the length of your index finger, so a little bit shorter than that. The original aortic aneurysm repairs, sometimes they didn't size them basically from stem to stern. I mean, it's a very high morbidity, mortality procedure if it's an open surgical repair. This patient went home the next day, which still just blows my mind that they can do this. I mean, you repair an aortic aneurysm, holy smokes, and they walk home the next day. I mean, you go home after, you go see them after the procedure in the afternoon, and they're sitting up drinking coffee. One of the other issues that patients that we see or treat are patients with pelvic pain, which can be caused by a variety of problems. The two that are amenable to our treatments would be fibroids, which can cause really heavy bleeding, pelvic pain, discomfort, irregular menstrual cycles. So what we can do is we can actually plug up. Let me just get to the. And this is what they look like actually on an MRI. You can see these large, huge masses right here. They're filling up with X-ray or MRI dye here, okay? And these distort the uterus, and they can make it look like a pregnant uterus. I mean, this is the belly button right here. This is the size of this woman's uterus, all right? You can see why she's having a little bit of pelvic pain, all right? So what we can do is the alternative, typically you treat this with a hysterectomy, you just take it out, okay? The treatment that we can do is we can actually just plug up the arteries just to those tumors, let the tumors die, the tumors shrink, and patient symptoms abate. And that works about 90 to 95% of the time. So this is what it looks like. We just slip the little microcatheter out to the artery. You can see these are the little tumors here. You can see the fibroid tumors, which are just very benign tumors. They're not cancerous, but they cause problems because of their size and bulk. We inject those little tiny particles. I showed you the electron micrographs. All right, and this is what the blood flow looks like. You can't see the particles, but all of the little arteries that go to the tumor are plugged up, so now there's no more blood flow to these things. No more supply to these benign growths. And then we do it on the other side. And all this is from a single puncture on the right groin. All right, this is what it looks like on the other side. You can see see the fibroid blush a little bit better on this side. You can see there's a fibroid there. You can see part of the fibroid blush here. There's a big one right there. All right, and this is what it looks like after we inject those particles. Just no flow at all, okay? And again, this is the before and after. Before, you see how vascular, this white stuff here is the dye that we inject in the patient's body, and wherever there are blood vessels, that's what turns white. All right, so you can see how vascular these are. Now, after we treat the patient, we bring them back, we inject the dye. There's no enhancement anywhere on these growths, all right? And this patient's fibroids eventually shrank, her symptoms abated, and she did really well. She was, we keep people overnight basically for 24-hour observation, but they go home the next day on some oral pain medication. Sometimes patients can get varicosities in their, varicose veins are basically just a dilated vein that doesn't allow blood to go forward properly, okay? So it's like this distended, stagnant vein, and most commonly we think of them in patients' legs, but you can get varicosities anywhere in your body, all right? Sometimes varicosities occur in a patient's pelvis, in a female pelvis. So if you look here, actually, this is a very dilated, distended vein. There are all these pelvic veins here, and this patient's having pain because the blood just kind of stacks up in her pelvis. It just can't get out, all right? And you get all this back pressure from this big, baggy vein. So one way we can treat that is we plug these veins up with coils and plugs and such. That takes the pressure from up above off of these pelvic veins, all right, and that is what helps abate or take care of the patient's symptoms. This procedure actually, was more just for curiosity's sake than anything. I mean, there's some debate over the efficacy of this or whether or not pelvic congestion syndrome is even a real entity. But usually patients that get sent to us they're at the end of the rope. They have no other explanation. It's sort of a diagnosis of exclusion, and it's sort of like one last try to help them get better. Tumors. You can see this is another CAT scan, all right? These are these low, these darker spots here. These are tumors in a patient's liver, all right? Again, this is another place where we can use our little particles to treat. Now, one procedure that I'm really excited that we're going to be starting to do, we're going to start doing here at St. Agnes is something called Y90 embolization. And what it is those particles that I showed the electron micrograph earlier on, they actually have radioactive yttrium-90 attached to them. So you can deliver that stuff in a very high dose just to the tumors. So you can have a super high radiation dose to shrink those tumors up and spare the rest of the liver. And this is with patients where we did this. The reason I just show these pictures is just to show that these can be very technically challenging procedures. You have to plug up the arteries that go to the bowels before you can inject these radioactive particles, because those particles don't always just go the direction you want them to. They go everywhere. So you got to make sure they don't go to someplace important like your bowels. You don't want radiation to the bowels. You'll get radiation necrosis and lots of bad things, all right, mucositis, inflammation. So you have to plug up, there are two main arteries. It's this guy here, which is the gastroduodenal artery. This one's easy. And then it's the real fun one, this one right here, this little itty bitty guy. All right, this is crucial. It's called the right gastric artery. It goes to the stomach. You can't move forward in the procedure until you find this little guy right here and you plug him up. And it always makes for a good time finding this one. So there it is. So we plug up the gastroduodenal artery. This is the right gastric. I like to show this picture because I glowed because my attending didn't think I could get into this and embolize this thing. I did it like in about 5 minutes. So he said I was ready to go. And then we bring the patient back a couple weeks later and we actually inject the particles. And we don't inject it to plug up the tumor. We just inject it just to the tumors to get them a high radiation dose. Okay. Another thing that we can do is we can actually have these special needles that are either charged with microwave or they can freeze tumors, and we just put them right in the tumor and we freeze the dang thing. All right, here's a patient with a lung tumor. This patient had exhausted all of her other treatment options. She had used up, she couldn't take any more radiation. There was no more she had no more chemotherapy options. So the question is, could we try to treat this tumor with a radiofrequency ablation? This is a procedure that we did here at St. Agnes. So I used the CAT scan to guide a needle, the special needle right into the right spot. So you can see here it's right in the middle of the tumor, and basically I know how much of an area this thing is going to cook. We get a sense of, through lots of studies, how much area it's going to actually ablate, and we ablate that. And this is what it looks like after we treat it. You can see we've just basically hammered all the tissues around this tumor. You can't see the tumor in here, and then we watch it to make sure it doesn't come back. That patient went home the next day, and she probably could have gone home the same day. She did really well. Yes? We can, yep. Yes?
Why wouldn't you do that treatment first before putting somebody through chemo?
A lot of times it's because there's not enough data to support it as a first-line treatment. In the lung, it's debatable right now. I mean, it's sort of equivalent with radiation treatment and surgery. It's sort of equivalent with those three, but surgery has more data behind it, and it's still a pretty good, pretty safe procedure. And radiation, just doesn't have the complications, the short-term complications of this. Lung's like a balloon, so a lot of times we get a collapsed lung when we do this. So it's not a totally benign thing. But we also do this in kidneys, livers, bone. The kidney is really, really impressive because that one is that's when we send the patient home the same day. I mean, you freeze the tumor in the kidney, they have very little pain, and you form an ice ball so you can see very well what you've ablated, and then they go home the next day, or the same day, I'm sorry. It's a wonderful procedure, and that one's very effective. So basically, to rehash, our procedures are minimally invasive. Most of the incisions, again, are just a few millimeters in size. Low complication rates. That's probably the biggest sell is just have very few complications. Definitely very, very, very few serious complications. Sometimes, you'll tear a blood vessel and it bleeds a little bit, and you just have to treat that. But overall, extremely low. Nearly all my patients go home the same day for the procedures that I do. Once in a blue moon, they have to stay overnight. I mean, a big procedure like an aortic aneurysm repair, they need to stay overnight. Liver embolization, you probably should keep them overnight. But a lot of patients go home the next day, or start going home the same day. And we provide procedures across the spectrum of specialties, and I think that lends itself to the fact, or as a result of that, we largely toil in obscurity because we're sort of the backup plan. All right, what kind of questions? Yep. Oh, in the past month, we've probably done, or past 2 months, I'd say we've done maybe what, six vertebroplasties. So, oh, I'm sorry, how many vertebroplasties did we do here? And thank you. And in the past 2 months, I'd say we've done 6, or maybe 3 a month or so. That's relatively new that we've started offering that. Well, typically you want to give the patient a chance to get better just on pain medicine. So you give them a couple weeks, but you give them the options. I mean, the nice thing about the vertebroplasties is the pain's gone if it works, all right? In which it works, 80% of the time, 90% of the time. There was some argument over whether or not it's effective, but the reality is I mean, when you do the procedure, it's an amazing procedure. I mean, you put the cement in these patients, they get better just instantly. It's a wonderful procedure. Other questions? Yep.
Is the patient reliant on their primary care physician to bring someone like you in on their case?
Well, you can always call us directly if you know about us. But that really highlights or emphasizes the point that a lot of people just don't know what we do or what we're capable of. And that's why I'm here today, is to try to get the word out that we can do a lot of really neat things. It's just hard to describe one thing, because I mean I could just talk about aortic aneurysms for an hour. If you're really curious as to what the full capabilities are, there's actually a Society of Interventional Radiology website, and that has a really nice listing of the variety of procedures that we perform and sort of the description of and animations of what we do. So if you're curious, you can go to the Society of Interventional Radiology website. Other questions? Yep.
Is there capability to repair brain aneurysm here? I wasn't sure, but.
No, we can't do that here. That requires, brain aneurysms are a very different beast. They require a very intensive neurological support. You have to have a special X-ray unit called a biplane unit. I don't know if you remember the picture of the lab that I had there, but that had basically it was just a C with a thing on each end. Well, a biplane unit has 2 of those, so that you can look at the brain in 2 projections, because the vessel anatomy is very complicated there, and they're very, those vessels are very fickle. So you have to keep your wire in the right place all the time. I mean, you perforate arteries in the brain. It's very easy to do, and unfortunately the consequences are a little more severe than if you do it in other parts of the body. Brain doesn't take a joke.
But once you fix an aneurysm, and what's the length of time is it good for? Is it good to go, or is it?
Well, we always follow them just to make sure. For example, an aortic aneurysm, that patient's going to be followed for the rest of their life to make sure it doesn't recur. It depends on the type of aneurysm. Typically, an aneurysm like that, splenic artery aneurysm, that thing's not going to come back. It's gone. We'll follow it to make sure, but it's gone. Once in a blue moon, those aortic aneurysms, the body will sort of find a new way to get blood flow and pressurize that aneurysm sac again, and then we'll have to go back in and revise it a little bit. So that occurs a little more frequently. And that's the trade-off with doing that versus surgery, is that surgery, it's fixed, but you have to hoe that row, so to speak. So there are trade-offs to everything. Other questions? Yes.
Are there radiologists in your group that do brain aneurysms at other facilities?
Yep. Dr. Peebles, Dr. DeCasso, they embolize the coil intracranial aneurysms. Theta Clark is where they do them currently. Yep. Other questions? Oh, some of the toys? Sure. Well, the big red thing with the seat of pants in the middle of it, that's the stent graft that we use to reline the aortic aneurysm. You probably saw the angioplasty balloon. That balloon is humongous. That's a huge balloon. Most of the vessels that I monkey around in are anywhere between 4 to 8 millimeters in diameter, which is about 1/3 of an inch, 1/4 to 1/3 of an inch in diameter. The catheters themselves go anywhere from, you probably heard the term French. A French is 1/3 of a millimeter. All right, so if you hear something like a 30 French catheter, which I think is what a Foley is, that's a 1 centimeter catheter. So most of the French sizes that we deal with are anywhere between 3 French and 8 French. So most things are 1 to 2 millimeters in diameter, sometimes up to 3 millimeters in diameter. Very small stuff. The wires, I have a variety of different wires. I mean, you can imagine within each type of category of device, there are multiple subcategories. So different wires do different things. Some are very stiff. So for example, if you have a really tight blockage that you can't get your balloon over the wire through the tight blockage, well, you change to a stiffer wire, and then you can really hammer through the balloon to get it to squeeze through the blockage. Other wires are very soft and pliable, and they can go. You saw how I made all these loops and turns and whatnot. those wires allow us to get to those very far out distant small places. Some wires have a special coating on them that when they touch water or blood, they can become really slippery and slick. And that helps us get through really tight blockages. Others have are kind of wrapped in a way that are easy to handle and are very soft and pliable, and makes it easy to exchange things and keep our spot. What are some of the things we had? There's a device here with like a screw on it. That's called an endoflator. That's the thing that we use to pressurize the balloon. Thanks, Mary. You can hold that up, and it actually has a pressure gauge on there. And the balloons, interestingly, balloons, a lot of the balloons are calibrated. The pressure correlates to a specific diameter, and so the balloons will, you get a balloon that will range from 3.5 to 4.5 millimeters in diameter depending on the pressure. And we have a little card that we use. I know what diameter I want to get to. We just crank it up to that pressure, and if it's open, I know I got that vessel to 4.3 millimeters. There was a red syringe here that had some junk in it, and if you look really closely, those are actually those embolization particles. All right, and those are made of gelatin. So you get an idea what those particles look like. We just, the syringes are normally they're sterile. We get in the right spot. We mix a little X-ray dye in there so I can see where the particles are going. Inject the dye with the particles in it from that syringe. I included a dialysis catheter because we just put so many dialysis catheters in. That thing, compared to what we normally do, that thing's a hose. And it has to be because you need access to a lot of blood in order to efficiently dialyze the patient. You got to basically do their blood volume. So to do that, you need a large bore catheter until you can get a more stable access, which is what those fistulas are. I don't know how many people have seen a fistula in a patient's arm, but that's sort of the long-term goal because it's a little safer. We have a couple stents. Oh yeah, that's a snare. There's a little lasso here, a little gold lasso. And that's our snare. We use that to snare. Usually we use it to snare the vena cava filters to pull those out. But I've used them to snare other things. Sometimes things get lost in the patient's body, and you have to go in there and snare them and get them out. And go ahead.
Those IVC filters, were those always retrievable?
No, the original ones were not. The original ones actually went through as I recall, a 30 French sheet. So you needed a 1 centimeter hole in the jugular vein to put those in. But again, a vein is like a garden hose, and it was really not a big deal. A vein is not a high pressurized venous structure. That's why we puncture veins in the arm, put IVs in all the time with no consequence, because it's just a low pressurized thing that you can compress it and get control. An artery is a totally different beast. But the original ones, they were not retrievable unless there was some sort of dire circumstance. Pretty much all of them are now.
Dr. Smith?
Yes.
We have a question here in Waupun.
Okay.
With the procedures you've been talking about today, from an insurance coverage perspective, are most of those covered by insurance or are any considered experimental?
They're all covered.
Okay, thank you.
You bet. Other questions? Well, I appreciate everybody taking the time to come out and show a little support and humoring me, I guess. So, thank you.
Excellent, very informative. Thank you so much.